titled Addressing Substance Use Issues in Primary Care, SBIRT and Emerging Opportunities. The goal of this webinar series is to provide information on critical policy, design, financing, and practice issues related to integrated care from the national and California perspectives. The webinars are free, open to all. They're held from 12 to 1:30 p.m. on the dates indicated on the schedule, which is located on the CIMH website, which if you want to view the schedule or register for future webinars, please go to www.cimh.org. You need to register online for each webinar you plan to attend. The webinars are recorded and posted on the CIMH Integration Initiatives webpage a few days following each event. My name is Victor Kogler. I am Executive Director of the Alcohol and Drug Policy Institute, one of the co-sponsors of this series. Our presenters today are Eric Goplerud and David Pating. Eric Goplerud is a clinical psychologist and research professor in the Department of Health Policy at George Washington University Medical Center. Dr. Goplerud is currently Director of Ensuring Solutions to Alcohol Problems, a research and communications initiative in the Department of Health Policy that is supported by a grant from the Pew Charitable Trust and focuses on improving access to effective and affordable alcohol treatment. Prior to joining the school's faculty in 2002, he held a number of executive positions at SAMHSA and was a senior prevention policy analyst at ONDCP. He also directs the Center for Integrated Behavioral Health Policy. His work there focuses on the integration of behavioral health into national health reform, improving access and financing for behavioral health in primary and specialty medicine, and engagement of businesses, insurers, and EAPs to promote access to effective, affordable behavioral health care. Our other presenter is Dr. David Pating. He is the Chief of Addiction Medicine and Medical Director of the Chemical Dependency Recovery Program for the San Francisco Kaiser Permanente Medical Center. He also serves as Northern California Regional Chair for Kaiser Permanente's Addiction Medicine Chiefs and Chemical Dependency Quality Improvement Committees. He has an academic appointment as an assistant clinical professor in psychiatry at the University of California, San Francisco School of Medicine. Dr. Pating is past president of the California Society of Addiction Medicine and a member of the California Psychiatric Association, California Medical Association, the California Healthcare Association's Behavioral Health Advisory Board, and the Mental Health Services Act Oversight and Accountability Commission. Before I turn things over to presenters, I'd like to tell our listeners that if you have questions, you will see in the webinar control box, the control panel on the right-hand part of your screen, a little window for typing questions. And due to the large number of attendees, this is our most, we had almost 300 people register for this webinar. We can only take questions that are posed to us in writing. So please type those into the question box on your screen. We will pause twice during the presentation for questions briefly and then open it up for further questions at the end of the session. So with no further introduction, we will turn it over now to Eric Goplerud. Thank you, Dr. Goplerud.
Thank you, Victor, and thank you, Gail, for inviting me to speak with you all about integrating mental health or integrating substance use into patient-centered medical home and integrating substance use issues into primary care. Let's skip to the third slide. Okay, next slide. And the reason that it's important to address substance use disorders in patient-centered medical homes and in the primary health care system as it's being developed is that substance use disorders and unhealthy use or hazardous use of alcohol and other drugs are extraordinarily prevalent in primary care. The gap between the need for treatment and the identification of people who have a substance use problem is very great. We'll discuss a bit about what the costs of unmet substance use disorders are. David Pating will describe the effectiveness of simple screening and treatment models that have been well developed and defined in research but are infrequently done. And then we'll talk a bit about what are the effects if screening, brief intervention, treatment, and recovery supports are delivered. And then sort of an overarching theme is that when integrated care is delivered, whether it's integrated mental health care, integrated substance use care, or integrated physical health care, both patients and providers like it. Let's go to the next slide. Now, this slide summarizes information from the Centers for Disease Control and shows the proportion of premature mortality that is associated with different characteristics. You'll notice that 40% of the causes of premature mortality come from behaviors. Behaviors such as exercise, eating, alcohol use, tobacco use. About 30% are associated with genetics. Environment, the socioeconomic environment, about 15%. 5% is environmental exposure, environmental hazards or stress. And only 10% is associated with the medical care that is available. So if we, in primary care and also in behavioral health, can influence some of those other factors, behaviors, socioeconomics, environment, we will have a much greater, we have a potential of a much greater effect on premature mortality and morbidity than expansion of medical care. In the mental health and public mental health, there's been a lot of concern over the last 5 years or so in the findings that people with serious mental illnesses served in the public sector in studies in at least 8 states die on average about 25 years younger than their peers. There is really very convincing evidence now in the substance use environment that people who have addictions, who have received treatment for substance use disorders, appear to die at least as prematurely, and they're dying. Various studies show between 18 to 22 or 23 years premature mortality, and they're dying from many of the same conditions that people with mental illnesses are dying from cardiovascular disorders, from diabetes, from stroke, from cancer, many of those associated with smoking. Let's go to the next slide. In fact, comorbidity ought to be expected. This slide comes from a study from Washington State looking at the healthcare conditions of citizens who are on general assistance, who are unemployed, unemployable. You can see that in the blue circle, only 31% of people who are unemployable who were served by the Washington State General Assistance Program only have a chronic physical condition. A substantial portion have a mental illness. I'm trying to look at all of these different percentages here, but overall 52% had a substance abuse or a mental illness that were identified. And the comorbidity of having a mental illness, a substance use disorder, and a chronic physical, one or more chronic physical illnesses are common. So what you should be expecting is that people with a substance use disorder are likely to both have a mental illness, depression, anxiety, or other primary mental illness, and or physical illnesses, and they need to be treated holistically. Let's go to the next slide. So what drugs should we be looking at? This comes from the National Survey on Drug Use and Health and is the prevalence of last month use for persons aged 12 and over. And if you take a look, yes, marijuana is common. About 15 million people report having used marijuana in the last year. Other drugs, about 10 million. The drugs of which you hear a lot in the paper or the greatest concerns, heroin, OxyContin, methamphetamine, very small percentage. The drug, let's go back to that slide though. Go in the wrong direction. Okay, the primary drug of abuse is alcohol. 140 million. Yeah. No. Next slide. Nope. Other direction. Other direction. There we go. Oop, too fast. Anyway, okay. From the NIAAA reported 12-month and lifetime prevalence rates for alcohol dependence and other non-nicotine drug dependence. For about 4.5% of Americans over the age 12 have met the diagnostic criteria of alcohol dependence in the last year, and a lifetime prevalence of 12% of adolescent and adult population. The annual mortality associated with alcohol use is about 85,000 people annually. If you look at the rates of dependence for other drugs, this is non-tobacco, it's about 0.6%, and lifetime is 2.7%. And as I was mentioning before about comorbidity, the comorbidity of alcohol use and other illicit drug use or prescription pain medication misuse is very high. The overlap, dependent on how we do the analysis, is anywhere between 1/3 to 2/3 of people who meet diagnostic criteria of drug dependence or drug abuse also meet criteria of alcohol dependence or alcohol abuse. This is one of the reasons, a primary reason why we focus in doing the screening, brief intervention, and treatment on asking about alcohol and about tobacco, is because they're both prevalent, and if you identify people who have problematic alcohol use, you likely are also picking up people who have problematic drug use. They will also be in your sample. Let's go to the next slide. But it's awfully difficult to try to figure out how is alcohol or drug affecting the populations for which we are responsible in the public sector. We have just released, George Washington University, have just released for public use an update of our alcohol cost calculator. And what I've put up on this slide and on the next slides are the URLs for you to go in and use it. This is a publicly available resource supported in part by grants from the Pew Charitable Trusts and from grants from some pharmaceutical companies. What the alcohol cost calculator, or the substance use calculator, does is it computes the cost of untreated alcohol, drug, and misuse of prescription opioid for businesses, for Medicaid, and the uninsured, and then identifies the steps that employers and public sector caregivers can take to address these problems. The calculator is anonymous. It is a public resource at no cost. It's based on the enormous surveys that the Substance Abuse and Mental Health Services Administration does every year, the National Survey on Drug Use and Health, which asks about 75,000 people a year about their alcohol, drug, tobacco use, their health status, mental health substance use treatment, and then a variety of sociodemographic information. We combine 3 years of that data, including about 210,000 respondents, in order to produce the engine behind our substance abuse cost calculator. The calculator has been looked at both by federal agencies and by businesses, by business groups, by public sector groups, endorsed, and is widely used. Let's go to the next slide. So if you go out to alcohol cost calculator, this is the screen that will come up. And if you look towards the bottom, it says either learn about employed and insured or learn about Medicaid and uninsured. And if you were to click on the first one, it takes you into screens which allow you, if you're an employer or working with employer groups, to identify what industry sector that you're in, your geographic location, number of employees, and to then get an estimate of what the prevalence of alcohol, drug, and opiate use is in your population, among their families, and what it is costing in business relevant terms. So days of work missed, health insurance costs. But for Medicaid and uninsured, if you would click on the Learn About Medicaid and Uninsured, and up would come then the next slide. So, and what I've done in this is to include, this is what the slide would come up. It would ask first about the population. And in this I have used the estimates from the Kaiser Family Foundation of the number of people who are covered by Medi-Cal and the number who have no insurance. And for California, that's a very big number, more than 12 million people. The next is to identify, it's a slider screen, what state where your population lives. Or we have another option which allows you to select major metropolitan areas. In California, we have the LA area, San Francisco area, and the Riverside area. Since the prevalence of alcohol and drug use varies somewhat from metropolitan area to metropolitan area. This can also be done at the sub-state level, at the county or sub-county levels. So if Alameda or Orange County or a section of San Mateo were of interest, you could enter that into your population, and then you go to that little button on the bottom that says Calculate Now. We'll go to the next slide. And this is what comes up for California. Of the 12.7 million people who have Medicaid or who are uninsured, we can use the National Survey on Drug Use and Health, comes up with this estimate of the number of people who have an alcohol or drug abuse, an alcohol abuse or dependence, 1.5 million in this population. Illicit drug abuse or dependent of about 750,000. Pain medication abuse or dependence, and this is people who are misusing pain medications for purposes other than what they were prescribed. And then for any substance use dependence, abuse or dependence, as you can see, the numbers don't add up because there's such a substantial overlap between those people who meet the criteria for alcohol disorders and other illicit drug disorders. Next, we take a look at what is that costing? What's the extra health care costs? And a per capita cost of about $201 per person, or for all of California, about $2.5 billion in excess health care costs because because of the illnesses and injuries associated with use of alcohol or drugs, or the cost of treatment for primary alcohol or drug use. A rather big number, at least it's a big number to people outside the Beltway in Washington. Let's go to the next slide. But there are other consequences, other costs than healthcare costs. And what we're able to do because of the questions that are asked in the National Survey on Drug Use and Health is to take a look at what are the some of these comorbidities. What are some of the things that are associated with these conditions? So we can provide and do provide here an estimate of what's the prevalence of serious psychological distress, which includes generalized anxiety disorder, depression, self-reported stress, among those people who have an alcohol use disorder, illicit drug use disorder, pain medication misuse. The proportion, the number who had a major depressive episode, major anxiety, who reported driving under the influence of alcohol or drugs in the past year, who reported ever being arrested or booked. So what we're building here is why it is worthwhile at the county level or at the state level to attend to increasing identification and treatment of alcohol and drug problems, because it's not just going to show up in people coming into the emergency department with an overdose or from crashing their cars or being victims of violence. It's also going to show up with major depression, with a DUI, come in through the criminal justice system. Let's look at the next slide. Now, we can look at, so we've been mostly talking about the costs of not identifying and not treating. On the basis of a substantial literature review, we can also estimate what it would cost to treat, oops, my screen just went dead. Okay, what it would cost to treat a portion of those people, identify and treat a portion of those people who have an alcohol or drug use problem, and what the savings would be in terms of reduced healthcare costs. Now, on average, for a Medicaid and uninsured population, only about 10% of those people who have a substance use disorder will report having received any treatment in the previous year. So what we have here is a slider where it says percentage can be modified, where if we increased, currently there is an investment in screening and treatment. It's getting you about 10%. But if you were to increase that rate to 20%, the figures then are adjusted, and what we have are how many folks are likely to be treated in California at 10% of those who have a substance use disorder, what it would cost, and this is an average cost per person treated, and then what the treatment benefits would be in reduced medical, mental health, and nursing home costs. This is based on research coming from Washington State, where they looked at individuals receiving Social Security insurance benefits, SSI benefits, who received substance use treatment compared to those who had a substance use disorder and did not receive treatment. So again, for people outside the Beltway, a savings of $790 million a year in healthcare costs, just if you treat the current level, the 10%, is a pretty remarkable amount. If you increased the rate to 20%, you would have a correspondingly double the estimated cost savings. Presently, we identify and have under active treatment between 45 and 50% of people who have a major depressive episode are under active treatment. If we were to reach that level of identification and treatment for substance use disorders in the Medicaid and uninsured population, the cost would go up. It would be a cost of roughly $2.5 billion. But the savings to Medi-Cal and to the counties in healthcare costs would be correspondingly great, whatever, 5 times, about $4 billion. But let's look at what some of the other costs and savings are for increased rates of detection. Let's look on the next slide. And all of this is on the calculator at the place where I showed you. So please, I encourage you to go and take a look and play around with it and use figures for your area. We also looked at where are some of the other places where we could be looking for savings. And again, some of the studies at Washington State were particularly informative. Again, staying with the 10% of people who currently are treated in California with a substance use problem. There's a different set of studies, so that the treatment costs are a little different. The benefits, which are more associated with employment, decreased crimes, decreased cost of criminal justice processing, and incarceration, are at an even higher ratio. So we estimate there the cost benefit is about 3 to 1. For every dollar that's expended, there's about $2.5 to $3 back in reduced costs of crime and increased income. There is a detailed methodology paper that is back behind the calculator, and substantially more information that's packed in it. So I encourage you to take a look at it and use the calculator. It helps to build the case as to why it's worth, in these times when there are cutbacks everywhere, where we have stretched Medi-Cal budgets and layoffs and all kinds of economic distress, why it is a good investment that shows payoffs in healthcare and payoffs in criminal justice costs, and clinically it has good outcomes as well. People are better. Let's go to the next slide. Now this slide just sort of hammers again this point about what our current rates of identification and treatment of people with an alcohol or drug problem. For people who meet the diagnostic criteria of an alcohol use disorder, only between 7 and 8% of them receive treatment. There are another modest proportion who receive who go to mutual support through AA or NA or other groups, but only about 7 or 8% of those who meet the full criteria are being identified and treated. Other illicit drugs, heroin, for example, about 18% of people with a heroin dependence or abuse are under or receive active treatment. For marijuana, it's down at the 7% rate. For other drugs, it varies between 7 and 18%. For depression, as I mentioned, about 45% of people are screened and treated, with the greatest growth over the last 15 years in the rates of identification as being in primary care. For diabetes, for type 2 diabetes, about 65% of people with type 2 diabetes are under active treatment, according to the American Diabetes Association. For hypertension, the rates are 70%. These are diabetes and hypertension are perceived as being primary care responsibilities, and screening and managing diabetes and hypertension, and now increasingly depression, are perceived as that's what you do in general medical care. What David and I are sharing with you is that identification and treatment of alcohol and other drug use is poised to become another one of those general medical care conditions which can be effectively done within primary care. Go to the next slide. So unmet behavioral health care needs. We get a substantial portion of people who do not get treatment, that referrals often don't end up making it to the behavioral health clinics, and 2/3 of primary care clinicians say that they have a shortage of primary care providers. They can't access outpatient behavioral health care services. Let's go to the next slide. If a person does get referred for substance use treatment, do they get effective care? Now, this is a slide from Miller and Hester, a big table that they call the Mesa Grande, being from the University of New Mexico. They have assembled a huge table of alcohol and substance use treatment research, and Mesa Grande means big table. And what they have done is put in order from most effective to least effective more than 40 different types of alcohol treatments that have been studied. The most effective is brief intervention, followed by motivational enhancement therapy, medication-assisted treatment, social skills training, and community reinforcement. Now, what we often don't do is what's most effective. Now let's look at the next slide. What we often do are those things that are at the very bottom, that are either ineffective or may in fact produce poor outcomes. What's at the very bottom? Educational lectures. What do we most often do in DUIs? Educational lectures. General alcoholism counseling, psychotherapy, confrontational counseling, reading sort of from the bottom up, you can see that many of the things that are standard in substance use treatment don't have a very strong evidence base behind them. Let's go to the next slide. So what is effective? The National Quality Forum has identified 11 characteristics of effective treatment that are supported by the research. These are the 11 here. You can see screening, initiation of treatment, medication-assisted treatment, and continuing care management. Next slide. Where we want to focus our attention, the majority of people do not drink in ways that are unhealthy. 70% never exceed daily limits. This comes from the National Institute for Alcoholism and Alcohol Abuse. Another 21% are at mild risk, occasionally exceeding limits, daily limits, and are not expressing distress or harm. About 5% are in a harmful use that exceed daily limits on a usual basis and are experiencing harm. The 3% of severe dependents are at the high risk, are daily or near daily drinking very heavily, and are beginning to experience the signs of withdrawal or social and familial impacts. And only less than 1% are the chronic dependent, who may be ending up coming in through the criminal justice system or ending up in the some of the public sector substance use treatment programs. This comes from National Institute for Alcoholism and Alcohol Abuse. Next slide. Now, if we just wait long enough, many people will remit spontaneously. So if you look at the that blue dotted one, if you extend out to 20 years, the majority of people who are dependent are no longer dependent, although you have a high proportion of them who are in partial remission, are still drinking heavily. But for many people, treatment is unnecessary, or what treatment will do is to shorten the time to their remission. Next slide. So that the last arrow that I showed, this really is another way of showing that where is it that you focus your attention, what do you do at these different levels. What David will be explaining in just a moment is how we do the interventions at these various levels. But if we look at the left side of the screen, a person who is heavy drinking only may benefit from being assisted to change their own behaviors, or through brief motivational counseling will reduce their harmful or hazardous drinking. The further we get towards the right, the more necessary it is for the medical management of the dependents. And as we get to the far right, the need for specialized remission-oriented treatment. Next slide. So if we focus on that 21% who are in the low to moderate risk for substance use, what we see can be effective based on the research is widespread primary screening, very similar to what's being done now with depression, where there are lots of avenues early in the condition where a person is asked about their substance use, about their alcohol use, and provided very brief motivational counseling to help them generate their own options and plans for reducing the risk of their use. Let's go to the next slide. For those who are drinking in excess of the NIAAA and USDA limits on drinking or drug use, or who are drinking heavily one or more times a week, brief motivational counseling and medication management, both of which can be done in general medical care, is effective, and we now have a variety of medications and treatment options that can be used at that level. Let's go to the next slide. As we get out into that last 1 to 3% of people who are chronic dependents, that's where they're, and in some ways we could turn this into the 4-quadrant model, I'm sure, is this is where the specialty sector, substance use treatment disorders, integrated fully with medical and psychiatric care systems, is necessary to manage the severe comorbidities, and also to be have a chronic care model in which there are supports for remission and management of relapse. Let's go to the next slide. So this is a model here. This is a description of SBIRT. SBIRT stands for Screening, Brief Intervention, Referral, and Treatment. I somewhat argue with them that the R really should be screening, brief intervention, recovery support, and treatment to stay with people over time with a chronic condition. Through screening, over on the left-hand side, we can identify using standardized screening questionnaires what is a low risk, leading then to very brief counseling and feedback, moderate risk of unhealthy outcomes, which may then require 1 or 2 or 3 sessions of treatment, or more severe risk, which is probably requires specialty treatment or at least specialty consultation to support medication-assisted treatment in primary care. Let's go to the next slide. This comes, and we'll quickly go over this, the Center for Substance Use Treatment's SBIRT demonstration program. This is an old slide. Now there are well over 1 million, I think 1.5 million people who have been screened. 77% of them are screening negative or at low risk. About 16% are screening in the unhealthy level who receive just brief counseling, and 3% more severe problems and dependence or abuse. About 3.6% of all people who are screened have either the more complicated conditions or more severe dependency or comorbidities that require specialty care. This is primarily over in public sector locations, community health centers, emergency departments of public hospitals. Let's go to the next slide. The effectiveness when followed 6 months out after screening, brief intervention, and brief treatment is we had nearly a 50% reduction in levels of unhealthy use and about a 50% reduction in use of any illegal drugs. Next slide. These are additional SAMHSA-GIPRA measures. There is a reduction in the number of people who report being arrested, an increase in the number employed, increase in the number who have social connections, who have friends, and an increase in the number who are homed. Let's go to the next slide. Overall findings from Washington's Screening, Brief Intervention, Referral and Treatment Program, they found substantial reductions, and reductions in the way that you would expect and hope, which is fewer hospitalizations, fewer persons who are injured, more patients who are getting into treatment in the specialty sector. Next slide. Let's continue on. Next slide. Okay, so just to reiterate, what the basis of screening, brief intervention, and treatment is asking, informing or providing feedback, and then briefly discussing with your patient or with the client what they like about the use of the drug or alcohol, what are some of the negatives, and helping to resolve that ambivalence that they may have, and coming up with change talk about how to improve or change their unhealthy or risky behavior. Let's go to the next slide. I think we're at the end. Okay, this is a really terrific tool that NIAAA has developed called Rethinking Drinking, and this is the website, and it asks those 3 questions that I mentioned about alcohol as part of the consumption questions on alcohol. And so Rethinking Drinking, they also have some really good handout materials. Next slide. And now, are we going to have a break here, or David will continue? Victor?
Hi, this is Victor Kovler. We'll take a brief break here for a couple of questions, and then we'll proceed with Dr. Painting's part of the presentation. Dr. Goplerud, we had a question from Michael who says, a few years back, Rand Corporation did a study for the State Department of Alcohol and Drug Programs in California. I believe he's talking about the CalData study. And the report claimed that there's a $7 savings for every dollar spent on treatment, and this is a larger savings than the calculator projects. Do you know why there would be that discrepancy? Are you familiar with that, the study that he talks about?
Right, I'm familiar with Cal data. We did a couple of things with our study. First, we took the most conservative estimates that we could, and we went with the strongest, best designed evaluations. So, and then the third thing that we did is that we put a 10-year cutoff on published research studies. So because there have been so many changes associated with managed care, with changes in eligibility for different types of Medicaid or Medi-Cal and other health insurance, we felt that we needed to be comparable to our current environment. So therefore, while we looked and know about the Cal data, we chose to go with what were a little bit more conservative estimates of what were the savings.
I see. All right. Then we have one more question here from Dennis, who, let's see, used a little bit more colorful language, but says that why does not the substance use disorder field use these more effective interventions, and what are some of the impediments, or your thoughts on why we don't embrace these more effective strategies, or why we hold on to ones that don't seem to, that the literature tells us are not that effective?
I would rather focus on what the opportunities are rather than I think we as a field are extraordinarily good at beating ourselves up. And I think I'd rather focus on there now are really effective techniques. When I was trained as a clinical psychologist, we didn't have a single lecture about substance use.
Yeah.
When I went into the field, the accepted wisdom was you had to confront people with addictions and basically beat down their resistance through confrontation. The science has improved. We know that those aren't effective. So what we have now is really an opportunity to do better. And I think David will probably show us what some of those tricks, not tricks, what some of those treatments are.
Okay, well, thank you. And that is the our transition here to Dr. Pating, so I will turn it over to him.
Good afternoon, everyone, and thank you very much, Victor, for inviting me to speak today. I also want to thank Eric for a wonderful presentation. Eric, if anyone's worked with him, very distinguished scholar of national stature, but if you actually have ever met him, you also will know that he's quite handsome and debonair as well. So,
okay.
How's that for an introduction, Eric? I would like to thank our sponsors again, CIMH, the Alcohol Drug Policy Institute, the Integrated Behavioral Health Project, and of course the Mental Health Service Commission and Act, of which I'm on the commission. I'd like to share with you and talk with you today about doing these interventions that Eric has talked about in the real world, and in the real world, particularly of primary care. I call this real SBIRT, and if you've been around SBIRT initiatives long enough, you've gotten the word of the various monikers. There's California SBIRT, which is called CASBIRT in San Diego. Why don't we go to the next slide? Next slide, please. And in Washington is WASBIRT, but I call this real SBIRT because I'd like to try to see if we can live in the real world. And if any of you are not in the real world, well, you can call it whatever you want. So at Kaiser, we have KAISBIRT, and we have SBIRT and residency training programs. And through the Mental Health Services Act, I'd just like to say that there has been many opportunities to bring screening and brief intervention for substances into mental health clinics and into primary care clinics under both our community supports and services funding for MHSA and the Prevention Early Intervention projects. I won't go into what the Mental Health Services Act if you're not involved with that, but it was about $1 billion a year being put into mental health on behalf of Prop 63. Next slide, please. So let's go in and talk briefly about the rationale for doing screening, particularly in primary care, because I think that's really our issue today. I won't reiterate this data because Eric has gone over some of this, but not necessarily in this way. This is looking at primary care people that have walked into the clinic. And people walking into primary care at any one time, 5% have alcohol dependence, 7% have alcohol problems, and 8% are drinking at levels that the federal government has determined to be unsafe or put them at risk. So the question I always ask our primary care doctors is, are you picking out 1 out of 5 of your patients that have an alcohol use problem or at-risk problem? Next slide, please. And based on national surveys, what I'll tell you is most primary care clinicians are not screening for substance abuse. This was done in 2000 by the Columbia University Center for Addiction and Substance Abuse, CASA. And they looked at about 700 physicians and 500 patients, and only a third of the physicians were screening for substance abuse. In fact, when they asked the follow-up question, next slide please, next slide, only about 20% of physicians actually feel very prepared to diagnose substance abuse. You'll see there on the slide that 19% felt comfortable asking about alcoholism and 16% felt comfortable asking for drug use. Actually, on a national standard, this does not bother me as much as if you look to the far left, why only 82% of primary care physicians were comfortable asking about hypertension and diabetes. So maybe before we deal with the right, we should also deal with the left. So when they were given, physicians were given a hypothetical case of a 38-year-old married man or woman who presented with early symptoms of alcohol abuse, namely stomach pains, gastritis visible on gastroscopy, intermittent elevated blood pressure, job-related anxiety and stress, or trouble sleeping and irritability, they were asked, well, what do you think this was? And less than 10% of people mentioned that could be substance abuse. Most of the physicians did not think that the symptom cluster could be substance abuse. Next slide, please. So then we go to the next end of the spectrum, and we ask patients in focus groups, do your doctors ask you about substance abuse? And they usually will say no. I've actually talked to many addicts who actually went to their doctors for known alcohol-related problems. They told them that they were alcoholic, and the physicians didn't do very much except to acknowledge and say, well, I hope you'll take care of that. And we asked them, what would happen if your doctor did ask you? And patients will typically tell us that they should ask us. They're asking us about our sex lives. They're asking us whether we wear seatbelts. They ask us whether we stop smoking, but they don't ask us about substance abuse. Next slide. And so then we go back to the physicians and we say, your patients are saying that they're kind of expecting you to ask these questions. It's part of our medical duty, and patients have no concern about it. Why aren't we asking? And oh no, back 1 slide, please. 2 slides. Oh, did it not make it in? This stay here. So what we find out with physicians is that it really boils down to 3 things. That they're too busy, they don't know how to screen for substance abuse, and there's stigma. They don't like addicts and alcoholics. And that's come up on several surveys. So our real-world task then was working with physicians and getting physicians, which is really our key workforce, and physicians extenders and everyone in the primary care setting to be, again, doing this thing that works so well based on national evidence, is to try to overcome stigma, to increase knowledge, and to make it practical and expedient, and to fit into an 11-minute office visit, which is the average duration of a primary care office visit. And what I'm going to tell you here, and that's why you're seeing this tobacco cessation slide, is that this is not anything new. We've actually done this already. 10 years ago, physicians were not screening routinely for smoking and tobacco-related consequences. But in a very short time, about 90% of physicians now routinely ask for for whether patients are smoking and do an intervention. And more than that, in fact, I think it's very close to 100. I'll have to ask Eric the national statistic. But most physicians actually stop smoking, which I think is actually also a good thing. And if you're still smoking out here in the audience, I recommend that you quit. And the reason that we've been able to do this is I think that we've gotten tobacco cessation down to a very simple yes or no question. Do you smoke? Yes. Are you ready to quit? No. Okay, well, I'll come and ask you again in a couple of months. And our goal then would be to do this with primary care in a way that will work for them just as well. Next slide. So, oh, I see what happened. We got out of order here. Next slide. Keep going. And there we go. So physicians like to look at the brain and look at the body. So one of the things we can do is, so now we're going to go and do some real-world intervention with the doctors in your clinics. I usually start out with a lecture with something like this, that addiction, as you know, and I assume that we're talking in our webinar today to the already converted choir, is a brain disease. And you can see this is a PET scan of a person that's been addicted to cocaine, and you show them beautiful scenes of Hawaii, and nothing happens to their brain. And then you show them something that looks like powdered cocaine, and you see that little dot light up, that there is actually a little button in the brain that seems to get activated around drug use. So on the basis of that, it's a brain disease, and because it's a brain disease, it's a medical disorder, and because 20% of your patients are coming in with this, it's something that you should be asking about. Not only that, that if you ask about it, you'll have a significant reduction of about 40% of your hospital visits and emergency room visits and office visits are alcohol and drug related. You'll have a significant reduction in follow-up as well. So realizing this, next slide, I'm just going to walk you very quickly through the NIAAA screening guidelines with a twist towards increased simplification. What we're realizing now is that doctors haven't done this primarily because I think we haven't quite taught it right. We've been going at this in a very complicated way, trying to get people to understand what alcohol dependence is and trying to get them to follow up and know about DSM and do motivational interviewing. There's a much simpler way. Next slide. It really boils down to asking 3 questions, or actually 2 questions in 3 steps. So we want to ask 2 screening questions, do a basic assessment for risk level, and then do the BI, the brief intervention of SBIRT. It's 1, 2, 3. So this is where I'm going to ask you to take notes, or hopefully we can distribute the slides at a later time because this is meat and potatoes. Next slide. So here are the 2 questions. In the past year, have you had 5 or more drinks at any one time if you're a man, or 4 or more drinks at any one time if you're a woman? And then on average, how many drinks do you drink in a week? Actually, they ask how many drinks do you have a day, and then how many days do you drink a week, and you multiply it out. But it basically comes up to how many drinks do you have in a week. And what they found with these 2 questions, it really picks up those that are at risk. So if people drink above this amount, they're at risk for problems, and the prediction is that in the next 3 to 5 years they'll have a health-related or some related consequence to alcohol. That could be falling off a ladder, it could be a drunk driving, it could be an assault, or it could be something more medical like hypertension and exacerbation of some chronic condition. Next slide. So I like to leave my primary care clinicians with these guidelines. For men, the daily limits of safe drinking are 2 a day, 14 a week, or 5 at up to 5 at any one time. No more than 5. So actually 5 is considered a binge and is bad. 4 is okay. Or for women, 1 a day, 7 a week, or less than 4. Up to 3 is okay. And if you are above this, then you're at risk for an alcohol-related condition or problem. And I got to tell you, if you leave your physicians and your health professionals with nothing other than this, you've done a great service, because this takes out the whole stigma issue. This basically says, look, I'm not calling you an addict, I'm not calling you an alcoholic. I'm not saying you're even a hopeless drunk, even though I might think that sometimes. What I'm just saying is you're drinking above national guidelines, and then I'm going to give you some simple advice, and I'm going to tell you now what the advice is. You need to cut back. Drink less than this amount. It's not an offer to quit, and it's not an offer to give up a lifestyle other than a simple advice to drink less than these amounts so stipulated. Next slide, please. Now, at this point, typically in the algorithms, you're given these long definitions of substance abuse disorder, and primary care clinicians are saying, okay, you've got somebody at risk, now figure out what you really got. And this is what the clinicians really don't want. They only have a few minutes. And so we're going to draw an X through this. Next slide, please. Do we have the slide? Does it come on up? And we're going to recommend that you not actually go give them the definition, but you follow up with two other questions. So you have somebody at risk. We want to know, are they dependent? And there are two screeners, of which here's one called the conjoint screener, which is about 70% sensitive. And you may recognize it. Actually, it's the first several questions in the simple CAGE screening tool. Basically, you ask if somebody is at risk for the drinking over the 5 drinks a day or over 14 a week. In the past year, have you drank alcohol more than you meant to? Or in the past year, have you ever thought you should cut down on your alcohol use? And this will pick up if you answer yes to these two, this will pick up 70% of those that are potentially dependent, alcohol dependent. So you actually don't need to go over all the definitions of dependence. You just have to ask these two follow-up questions. Since my clinic in Kaiser implemented this, I've actually recently found a better set of questions that I want to post to you, and we'll show those next. Next slide, please. I'm actually going to recommend you don't use that set. You use these two better alcohol use disorder questions, and these have just been validated, and they're the Vincent screener. I want to thank Dr. Richard Sates on the East Coast who introduced this to me. So after you have identified somebody that's drinking over the recommended amount, you ask these two questions, and these are things I would recommend you take home. In the past year, have you sometimes been under the influence of alcohol in situations where you could have caused an accident? Situations where you could have caused an accident. And have there often been times when you had a lot more to drink than you intended to have? And the evidence is that this is about 70 to 96% sensitive, meaning it picks up about the alcohol dependence in 72 to 96% of the time. And it's very specific for only picking up alcohol dependence, 81 to 95% of the time. So if you find somebody that's at risk for their drinking, their binge drinking, for example, on weekends, they go to the bar and they have 10 beers, not 5. And then you ask them these two Vincent screener questions, you're really almost all the way home. Next slide. Because what you're trying to detect is people that you're going to give them some simple advice, but what you really want to know, are they going to be able to follow that advice, and eventually are they going to be able to stop? Can they overcome their compulsion to drink, their loss of control, and their continued use despite negative consequences, which is the definition of alcohol dependence? These are the 3 C's. Next slide. Now, I will tell you, depending on what system you're in, I've worked in a lot of systems now to try to do this, the VA, some county systems, and Kaiser. Every system seems to ask these questions differently. At Kaiser, where I work, we like to have our medical assistants, or proposing our medical assistants, would ask these questions as part of an alcohol as a vital sign project. So our medical assistants ask, do you smoke? Yes. And they put a check. And are you exercising? No. Put a check. And then the next question would be, have you drank 5 or more drinks at any one time in the last year? And then how many drinks do you drink on average a week? And based on that screener that's given to the physician, they will follow up with the intervention. When we do this at the VA likes to computerize everything, and so they will put screeners like this typically in their computer systems, which part of their intake. And then county systems have been working off of paper, of which we have the audit screening tool here with 10 items, but you can make up your own screening item with 2 items or 4 items, and whatever works for you. I just want to let you know there's no best way that we can gather to ask these questions other than just ask them, and then you get a sense of their risk, and then you do, next slide, one of 3 things. You're going to recommend, based on their risk, either that they cut back, or you'll do something called a brief intervention, or you'll refer them to treatment. Next slide. So let me tell you what I would like you to do most of the time. Somebody comes on in, they have a cold, a stomach ache, you ask them about, have you had 5 or more drinks at any one time in the last year? They said, yeah, I drink, when games, I really like to have about a 6-pack of beer. How much? And I drink a 6-pack. And then you say, I recommend that you cut back. This is not, again, a request to stop. It's just a request to cut back to safe or moderate levels. And then if they give you some guff, or let's say that their blood pressure is up, or you're a little more worried about them, if you want to step this up, you can do, next slide, a more formal intervention, which is formally the brief intervention, and this is where you add the statement, based on my assessment, you are at risk for future health problems. Now I advise you to cut back. So you can see, there's a lot to say about brief intervention, but it could be as brief as basically simple advice, or it could be as long as you want, tacking on as many reasons that you think they should cut back. It'll help you with your blood pressure. It'll help you with your wife. It'll help you with your job. I recommend you cut back. And the more of these that you give, and the wider your coat, the more powerful this intervention. And the evidence is about 10 to 30%, or actually about 20, 25% of people will significantly cut back. Next slide, please. I'd like to say one thing about motivational interviewing. A lot of people talk about these long things where you're supposed to have half-hour conversations weighing the risks and benefits of drinking, and it's called motivational interviewing. I like to tell you quite honestly, I try to teach motivational interviewing to primary care physicians, and I usually get 20 to 30 minutes in a lunch hour to work with primary care clinicians when I teach this. First of all, they normally say get an hour, but everyone shows up late, so there's 15 minutes, and everybody leaves early, so there's 15 minutes. So I try to plan for 20 minutes, and I go really quickly, and if I had to do motivational interviewing, I just wouldn't make it. So what I usually tell them that if you need to have a longer conversation than this, there are some people and experts, and this is where I would look to all of us in the mental health and substance abuse community to be able to provide that extra help to back people up in these busy primary care practices who can do a little more intense intervention. So I usually do not teach motivational interviewing. I leave it at this basic, simple, brief advice, and you'll see why I do that in just a minute. And you don't do this brief advice at every interview. You do this only really at what we call, through the Center for Substance Abuse prevention moments. This would be, for example, a new intake. That's a prevention moment. Somebody that has annual physicals, actually my colleagues say we don't do annual physicals anymore, we do health checks. I said, okay, well, do the brief question then. Can you do that? And they go, well, okay, but just don't call it annual physical. Or you could do it at an at-risk situation. Somebody falls and they have a black eye, but they can't tell you how they got it. I can tell you how you got it. So I'm going to ask you about some alcohol questions here. And at Kaiser, we actually have our employees are our members, or them as us, because we're a self-insured plan. So we incorporated it into some of our employees' health screens as well. And then based on that, you ask, and this is not the algorithm that you have here, but you can see that it's a stepwise approach. Do you drink or use drugs? And then if you drink, how much you drink at any one time, if you have 5 or more drinks. And then, if you do, I recommend you cut back. And then at Kaiser, we offered some options like, if you need some advice or help with this, we put pamphlets in the waiting room. We actually put TV sets with little talking heads saying how to cut back, but they were never viewed. And we actually made appointments with a behavioral medicine specialist, which is a psychologist, a social worker in our health clinic, that they could visit, but they never were visited. The reason you want those resources is not because they get used, it's because clinicians always feel like, well, what would I do if I find something? And we just like to tell them there's help. But in our experience, it's they usually don't need them. And when we go back several months later, those pamphlets we put on the wall are still there, although physicians are asking the question. Next slide. And the evidence is if they do it, 20% will significantly cut back in the next 6 months. Next slide. And it doesn't have to be much of an intervention. Actually, what you'll see here, and this is the Fleming study, they did 2 15-minute interventions, and you can see significant reductions in binge drinking episodes and binge drinking and quantity of drinking during binge episodes. And that's after 2 15-minute interventions. Now you remember the average office visit is 11 minutes, so we got to figure out something different here. So next slide. So when you look at actually some other studies, this is 1 5-minute intervention. You can see I won't go through the numbers here, but just believe me, there is significant reduction in binge drinking days to safe drinking levels with 5 minutes. Next slide. And I'm going to tell you, I think you can do it in 2 minutes. And that's my message to you. It's this super fast method, which is, have you had 5 or more drinks at any one time? Thank you very much. I recommend you cut back. And let's go on to the next issue because, no, not next slide. That figure of speech. So what you'll see here is a slide in which, this is the World Health Organization looked at, I think there's 5 countries in this, 600 people, so it's actually been tested cross-culturally. At baseline here, everybody gets a questionnaire in this World Health. In fact, they got the WHO Assist screening tool. And then you'll see that on the top line, with the control, on the bottom line, they get the brief intervention, which is someone talking to them, some sort of intervention. And what you notice here is on the control group, which doesn't get the intervention, they actually improve, and their number of drinking episodes and drinking days decreases. It is my belief that just asking the question is valuable. In fact, there's evidence of that. There's also evidence that some people will spontaneously remit, but I don't think they remit in the 3 months that the study was done. So I'm going to attribute this mostly to asking the question alone is curative for a significant number of people. And then if you follow it up with reasons why they should cut back, well, that's even better. Next slide. And the reason why this works is some simple dynamics which many of you probably know intuitively around doing stages of change work, which is what we've shown is with tobacco, diabetes, and now alcohol, about 20% of our patients that we're talking to are in the action phase, meaning that they're actually ready to do something to cut back their smoking, to manage their weight, or to decrease their drinking. About 40% are contemplators, meaning they're thinking about it. They may want to do it, but I'm too busy right now. I've got to log into a webinar. I've got to go after the webinar. I've got a meeting, and then I'll do it next week. And then there's another 40% that are pre-contemplators. They don't think they have a problem at all. And what I think you're activating with asking the question and doing it in the right way in a caring, supportive frame, feedback, empathic, motivating way, is you're activating this 20% that's ready to change. It's actually patient factors rather than clinician factors, but you're the catalyst and you're doing it. And the beauty of this, however, though, is that this is a very dynamic group. If you do this with a group that's contemplating, there's evidence that in 6 months, many of them will move significantly to action phase. And so what I tell people is that every 6 months, you keep saying, are you ready to cut back? After 5 tries, you get 20%. 100% of your practice will quit drinking. So that's a joke. So, but the point, though, is that if you do keep telling people enough and nagging them, as you should, nagging them about smoking and losing weight and doing exercise, we'll get great results. And the results are this. Next slide. In the small-scale way, okay, you don't have it. You will be saving $4.3 of medical costs in your clinics for every dollar invested. So the moral of this story is this, is that this is an intervention that works. Nobody's doing it. It's simple. It doesn't require a lot of knowledge. It doesn't require a lot of high-tech stuff. If you can just overcome the culture of your clinic and just do it, we know it will work, and great things will happen. So that's what I have to say, and I guess we'll take questions on that basis. Thank you.
Great. Thank you, Dr. Kading. We do have a few questions. One was about where can one get training in SBIRT? And this A related question was about for different levels of staff, whereas physician training or substance abuse counselors, given that there are different models for doing it, how can these different types of clinicians get training?
Well, there's been training that's offered on a grant basis throughout the state. I'm actually going to tell you, I don't know where, other than this webinar right now, I will tell you that the UCLA is offering it to residents, and UCSF has a residence training grant. The California Society of Addiction Medicine at its annual conferences, the next one's October in Newport Beach, has primary care modules where we routinely incorporate brief intervention. I think the best thing would do, I would assume, would go on the website and call CIMH and the Alcohol and Drug Policy Institute. You guys have training under the MHSA grant monies. Maybe we can use some of this to bring some of this training to the clinics. As well as, and this the Integrated Behavioral Health Project, which Mary Rainwater, the Integrated Behavioral Health Project, is talked to me about, interested in they're doing trainings regarding behavioral health and primary care, and I would hope and I assume that there will be trainings offered that as well. So I think at this point, contact the resources. There is an initiative out of the alcohol and drug programs to launch screening and brief intervention on a more broader level, but I don't have the exact times and dates of additional training to the centers.
All right, thank you. And then one other question before we resume here. What about patients who do not respond? Either there's continued denial or it's like, okay, fine, and then there are no changes.
Well, so that's what I'm looking for. So I think a better heuristic in terms of identifying dependence, rather than, again, using the DSM, is if you are identifying they're drinking above amounts that are recommended and they're having problems but then can't quit, then that's a referral, I believe, to specialty substance abuse care. So if they are drinking above amounts and they're not having problems, then they really haven't met an abuse or even a dependence diagnosis yet. They're really just doing what is legally their right, to drink and have a good time with amounts that are probably unsafe. But if they are having problems and can't stop and you advise them, then I think de facto you picked up somebody that I think needs a specialty referral for either evaluation or, if not, frank treatment. So very practical approach that I think can save you a lot of headache.
All right, and with that, I guess we will turn the microphone back to Dr. Goplerud, and we'll finish up the presentation. Hopefully we'll have some...
Hello?
Hi, Eric.
Okay, yes, I'm on now. Let me also suggest that there are a couple of very nice websites that people can go to find training and find materials. One of them is SBIRT, SBIRT.samhsa.gov, and that's a website maintained by the Center for Substance Abuse Treatment with lots of links out to training materials. There are at least 3 or 4 web-based trainings that can be accessed, including one developed by NIAAA as part of their clinician's guide. And David, you showed one of the screenshot of the clinician's guide. There are 3 training vignettes that have been developed, and through arrangements with WebMD, there are CMEs and CEUs that can be gained by viewing that those training sites. All of that is free. There also are training materials that Rich Sates has developed at Boston University that are online. And again, all of these are free. They're really, really nice examples of how to do the screening and then the feedback and counseling. So I would certainly suggest people access those. Let's go to the next slide. And I'm going to quickly run through a bunch of material and probably stop before we get to the end. Some of this is just the kind of evidence that my being a university-based researcher that I would want to share. This is the effect that is found with in a big health insurance plan of providing screening and brief intervention, primary care, in just random primary care. What they found in the 1 year following the SBI being delivered, you had reductions in psychiatric hospital days, in medical
Counter's Bounty clean? In this lab test, just one sheet of Bounty leaves this surface 3 times cleaner than the...
It reduced emergency department visits, but got the kind of increases that you want. And this is very brief counseling. You got increases in rates of people going and receiving inpatient hospital or partial hospital and intensive outpatient visits, psychiatric visits, and also what's not shown here is primary care visits increased. We also had increases in pharmaceutical expenditures, but they were more than off-balanced by the net medical cost savings from less hospital use and less emergency department use. So you got a change in the shape of care delivery a year after the delivery of a very brief service. Next slide. Now, for those people who have more severe problems, this is a list of the evidence-based approaches that have been shown pretty much consistently and without real differentiation between them as to which ones are more effective. All of them are effective, and this is for the more severe conditions. Next slide. When people with alcohol dependence are referred to a disease management program where they receive those services mentioned in the last slides, this is what happens to the shape of their services in the 12 months after receiving the disease management program or starting in disease management. We get that same pattern. Medical and psychiatric inpatient days go down, emergency department goes down. We even see reductions in partial hospital and intensive outpatient. And we see a corresponding increase in ambulatory mental health, substance use, and physical health care. Overall, a substantial savings in costs. Okay, next one, in healthcare costs. Next slide. So how does this fit into this patient-centered medical home that we hear so much about? Well, these are some principles here of a patient-centered medical home. Personal physician, an orientation towards the whole person, integrated, coordinated care, quality care that's supported by health information technology, access to care, and payment that recognizes that it costs something to do care management. Next slide. But if it's so good, why don't we do it? Well, as I teach my students here in health policy, the guidance from Deep Throat to Woodward and Bernstein is follow the money. Next slide. This slide looks at the quality of care. This was done by RAND researchers, Beth McGlynn and others, of what is the correspondence between what an evidence-based practice would suggest and what actually happened in primary care across about 25 different conditions. What they found was that primary care does a reasonably good job of doing history and systems. Medication is prescribed within range most of the time. Immunization's pretty well kept up to date. Physical exams pretty good. Laboratory tests are done pretty good. Surgery's done pretty good. Counseling and education. Most of what we do in mental health and addiction, talking to people, less than 20% of the time is there correspondence. Now, why might that be? Let's go to the next slide. Not a surprise. What gets paid for gets done. Now, these are the values that are applied to different procedures. I went out and said, okay, so what do you get paid actually for doing brain surgery? An RVU is the value that is set for a clinical service. It's a way to make everything comparable. It translates into about $40 per RVU. You can see that if you procedures and risky procedures are paid a whole lot more than do than our counseling. Let's go to the next slide. Here we compare the CPT codes or the procedure codes for the screening and brief intervention that David and I have been talking about. You can see that even when you compare them to regular outpatient visits, prevention visits, or psychotherapy visits, they don't get paid at anything like the rates for those other office-based procedures. So not surprisingly, we're not seeing them being used very often or being billed very often in general medical care practices. This is a systematic problem for almost any time where general medical care, the evidence-based practice would say you should be talking to the patient. It tends to be undervalued relative to procedures. Let's go to the next slide. These are the average reimbursement rates for the screening and brief intervention codes. For the code for 15 to 30 minutes for commercial insurance, and most for many Medicaid states, and then the Medicare rate. All Medicare patients can receive the screening and brief intervention. About 85 to 87% of commercial insurance, and 17 states, according to ONDCP, are paying on these CPT codes. I don't recall whether Medi-Cal is. Next slide. In your state, these are the insurers that report that they are paying on those CPT codes. They're reporting on their commercial insurance, meaning employed populations, and they're reporting to the Pacific Business Group on Health that they are paying on those SBI codes. If they're not, let me know. Next slide. This basically is just part of a rant that says that we're not paying for what we know is effective. Next slide. We also have another set of issues. We have privacy regulations and privacy laws that are federal laws that make it very difficult for primary care clinicians to communicate with the specialty substance use treatment providers and vice versa. An issue is called 42 CFR Part 2, which is the federal law, and then the state mental health and substance use privacy laws. Until we crack this part, it's going to be very, very difficult to share health information, which is absolutely essential for good patient care when we have such comorbidities between mental health, addictions, and general medical care. Let's go to the next slide. And this just further emphasizes the issue, which has yet to, it's going to be a tough one to resolve, of how do we communicate about health information while protecting patients from the disclosure of information which can end up hurting them. Next slide. Next slide. Okay. And this is just from the summary of the Institute of Medicine IOM report 2005. Basically says this is a huge problem and it's a medical problem, and that there are treatments which are effective for addressing these problems. I think at this point we'll turn it back to Victor, and we'd be happy to answer questions, but I think we're just about at the end of our time.
Yes, thank you very much, Eric. We do have a few questions. We'll try to do another 5 minutes or so, even though we'll go beyond our published ending time. I do want to remind everybody that these will be posted on the CIMH website. We're putting together an FAQ page where people can also download the presentation, and I think our last slide shows that the URL as well as the schedule of the remaining webinars. So you can see there where to go for more information or to download questions or copies of this and previous presentations. So to get back to the questions, there was a question about, with SBIRT, what about drugs other than alcohol? Marijuana, for example, and even, get into other things like cocaine and such. Does that come up? Most of the discussion has been in the concerned alcohol, which, of course, as one of the slides showed, was, a very, very commonly used drug. So the lines are open both for David Pating and Eric Goplerud, so you can both respond as you wish.
Eric, do you want to take the first crack at that?
Sure. The Center for Substance Abuse Treatment's SBIRT program has included alcohol, tobacco, and illicit drugs. What they have found and published a year ago now is that the effectiveness of SBIRT for other drugs is as substantial as it is for alcohol. When the U.S. Preventive Services Task Force did an extensive literature review to see whether they already recommend routine screening for alcohol and brief intervention, whether other drugs also should be included, their conclusion has been is that there are insufficient research studies to prove that it is effective. They did not say that it's not effective. They said there aren't enough controlled trials. There are research studies underway, including those, I think, one at Kaiser. So David?
My advice went, so I actually do ask the question now, you had 5 or more drinks, and then also, are you using any illicit drugs? If you do get a yes, the advice is not to cut back, but actually to quit. And I think you have to consider, even if it's using cocaine once a month, the pattern of use of either procuring it, possibly illegally, and the kinds of activities and risks are just are much higher on a sporadic use. So I would recommend people that if they are using drugs, that the advice is to quit. There is one concern about the issue of screening for marijuana. At any one time, it's 6% of adults in primary care have used marijuana. In my county in San Francisco, the percentage is probably higher, and there is a ballot in November to consider legalization of marijuana, which may make it kind of problematic to how to address this. But what I usually recommend within the primary care setting is actually a more cautious advisement regarding the use of marijuana. Only about 1 out of 10 people that use marijuana use it daily, and then of those that use it daily, only 1 out of 10 of those will have significant problems. So given that there's a high prevalence of marijuana use and a low rate of significant people that are having major social problems, I usually ask people, if it's really obvious that they're having problems, then advise them to cut back, but to just kind of take a no position on the issue of marijuana use in the primary care setting, unless, I guess, 2 exceptions. For adolescents, I don't want them using marijuana because it's a gateway drug, and for those that have obviously past histories of substance use, marijuana poses problems in primary care, potentially setting off the other conditions as well.
Okay, we had another question here. Does this change at all when the patient is an older adult? Would you approach them any differently?
Hi, this is David Pating again. So the issue about older adults is more imperative to screen for alcohol dependence. There's a lethal triangle among older adults of grief, alcohol use, and depression, and then with the increased risk of suicide. Older adults will present in a way that with less resources that we really definitely want to pick up earlier, and we want to pick them up particularly in primary care because only 3 to 6% of older adults will actually go to specialty services. So I think the thing about older adults is, again, being aware of the constellation of risk factors, the grief, depression, and the alcohol, but also being aware that they may not accept referral when a significant problem has been identified. So other than that, I have no reason to believe that the brief advice to cut back wouldn't work as well. Eric, actually I would ask you that in terms of the effectiveness of brief advice in older adults. I've not seen that specifically pulled out.
The main concern that I've seen recently about older adults is that they are on multiple medications which can interact very dangerously with alcohol or with pain medications. And so this very much is a place where primary care is at the center, because they're the ones who are going to be balancing all of these various medications. So there the discussion is around the healthy use of the multiple medications, or the interaction effects of the multiple medications and drugs. But,
and the guidelines are for older adults, it's 1 a day, 7 a week, or 4 drink limit. And so you would use the women's guidelines for adults over 65.
Great. Well, thank you very much. We've run over our time quite a bit, and I can see that we're starting to lose people. And so, again, I'd like to say we want to get the questions up on the website in FAQ format, the ones we didn't have time to address. I'd like to thank all the people who signed up and attended the webinar. We had a terrific response here. Our next webinar is next Thursday. No, it's not next Thursday. It's June 3rd, but it is Thursday. And the topic will be addressing mental health issues in primary care, the IMPACT model. And this will discuss the use of IMPACT and other mental health screening and brief intervention models in primary care settings. So we'll hear a similar sort of discussion about looking at mental health screening. The presenters will be Lori Alexander, a behavioral health care consultant with CIMH, Rachel Quintanilla of Project Vita Health Center in El Paso, Texas, and Brenda Goldstein of Lifelong Medical Care in Berkeley, California. So I'd like to thank you all very much. When you exit the webinar, you'll see a brief evaluation questionnaire, and we really appreciate your comments so we can know how well we did and how we can keep doing better on these. So thank you all very much, and we'll look forward to seeing you again on June 3rd. Thanks a lot.